Today I want to talk about some few diagnoses that is related to your eyes and very, very important. So the first one is retina detachment. So the retina is formed back of the back of the eye. Basically, that's where the main function involving you be able to see. And this is the lens. So if you have the lens here, that's usually what people see. But the actual action usually occur at the back of your eyes. So you have these retina here like that attached to and then you have the nerve coming in, the optic nerve. It comes in this way like that. So this is our retina. Sometimes something can happen to you and the retina can detach from the back of your eye, so your vision may be impaired. And it's very important to be able to know how they will present. And that is what most of the time your questions will be based on. How do you know that this patient is having retinal detachment? So is a separation of the retina from, it's just a separation of the retina. Okay, and the presentation, usually, I'll put signs and symptoms. Usually, how do they do? You see, this is acute onset, so it's emergency, it's acute, it is sudden. That's what the question will say, acute onset or sudden onset of vision loss, basically, sudden onset of vision loss. This is one diagnosis that has so many fancy names, so I pay attention to these names. In case you see it in, there's no one, you see it in the question or answer choice, they see flashes. So they see flashes, and they can see floaters, okay? You can see floaters too. There's a word that sometimes they use like curtain-like. So when you hear the word curtain-like appearance of vision, yeah, you're talking about retinal detachment. And then black spot, they also have black spot. Sometimes they use this cobweb description of your vision. That is an indication of a possible retinal detachment. And then sometimes you lose portion of your visual field is lost. That's also another way of describing. Then some people even describe, they have so many fancy words, like they describe it as hairnet, way of seeing things. You see hairnet, that means these are key signs of retinal detachment. So if you see this in select or apply or physical examination, or you're doing next generation test and they ask you which of these are you going to see, there will be a bunch of boxes on your physical exams. This is what you see. And like I said, this is an urgent, emergent, acute onset problem, and you have to do something about it. How does that happen? Well, it's usually trauma. So somebody severe trauma to your head, on the side of your head, either the temporal area. I think that's number one cause of retinal detachment, like a football player slam on the side of his head, and then the retina get detached completely from where it's actually functioning. Or it can be due to age. There's no trauma, very happy old age, and it detached. So that's why this one, if you see retina, diabetic retinopathy is the same thing. So if they give you a question of patient who has diabetic retinopathy, that means the retina is affected. They will have the same symptoms. They have flashes, floaters, curtain-like symptoms, black spot, cobweb, portion of visual field will be lost. So they see the same thing. Okay, this is an emergency. So treatment is emergency. So they need to have this attached back right away. So they go to surgery. There's no time to waste in these kind of patients. You don't have enough time to waste at all. Otherwise, they will lose their vision right away. So that is the treatment for that. Before they will need surgery. So before they go to surgery, so pre-op, if they present with this kind of symptoms, you tell them your plan as a nurse is to cover the eyes, okay, cover the eyes like a patch to prevent stimulation, and then anything that will prevent intraocular pressure, you have to institute, and we'll talk about it at the post-op. It's much better there. But you institute no sneezing, no coughing, no burning, all those things you tell them. Usually, the intraocular pressure is between 10 to and 20, 21. So this is normal pressure. If it goes up, it's like your ICP has gone up. So if they give you a patient like 22, 23 intraocular pressure, yeah, you got to do something about it. They're going to lose their eyes. Too much pressure. So after surgery, they go and fix the problem. They reattach the retina. One more precaution that just came to my mind. When they come in with the detachment, you place them on the side that is affected. So lay on affected. So on affected side. Okay. This is when they come in right away after they have a retinal detachment. So after surgery, so post-op. The main idea of the post-op management is decrease ICP. You want to decrease, but we don't call it ICP, intraocular pressure. You want to decrease it as much as possible. So there's certain things you can do to do that. You don't let them cough, no sneezing, they cannot sneeze. All this is going to increase their pressure. No vomiting. Okay, they can do that. They cannot strain. And this is the same thing, something you should know by now. You can spread everything out as much as possible. They cannot rub their eyes, no rubbing of their eyes, nothing like that. Okay, they shouldn't do that. And then no, this is immediate post-op. Okay, so you have to make sure the bed rest. And don't let them burn at the waist. Okay, they can't do that. They shouldn't burn at the waist. That increase in so they can kneel, but they cannot bend at the waist. Their head go down, and then they will increase the intraocular pressure. Okay, that's not acceptable. So those are some of the things you will do to decrease intraocular pressure. Of course, you have to keep their head of the bed at least 30 to 40 degrees. Okay, not higher than that. So that's the plan in terms of immediate post-op. So this is the treatment to decrease intraocular pressure, to avoid prevent them from using their eyes too much. So this is the same thing we're talking about post-op. So post-op, second number, post-op number 2. Don't let them move their eyes too much. So they need to prevent doing that. So no focus. Okay, no focused activity, such as like reading. Okay, usually when you're reading, you're very focused. Your eyes is moving rapidly too much. It's moving rapidly too much. You don't want that. Or if you're writing something, okay, they shouldn't do that. The number 3 things that they should do is you got to protect the eye. So you patch and you put a shield. But nothing pressure. It's no pressure on it. Because after the surgery, before surgery, they lay on the affected side, but now after the surgery, they need to lay on the unaffected side. Different things you need to tell them and to continue to do. Okay, they should also, when they go home, number 5, okay, you tell them to look for bleeding. Okay, look for bleeding. Okay, signs of bleeding, you should report it. Important. Look for bleeding. If there is too much bleeding, they see blood coming out from their eyes, or if they lose their vision right away, or if they see flashes or sudden pain, these are indication of detachment. We can prevent that. Okay, so this is the everything you need to know about retinal detachment. It transcends or it involve other um, pathologies. That means things that you should know by now. The treatment and the management is all based on the fact that it's an acute problem. You fixed it, then you give them ICP precaution, like stimulation in your nose, avoid stimulation in your nose. Okay. And then if they coughing, then you can give them cough suppressant to decrease that. Okay. If they vomiting, well, you give the anti-emetics. So you do this prophylactically. Prophylactically means you anticipate this may happen and worsen the problem. So you give those medication for them. They take it home and they take it before they start coughing. You don't want them to cough, so you suppress them. If you don't want them to vomit, you give them antiemetic. Then they start taking it. They strain when they have constipation. So you avoid constipation. So you give them stool softener, okay? And you tell them to increase their fiber, drink a lot of water, so hydration, okay? You don't want them to increase intraocular pressure, so no exercise at all. They want to exercise, but tell them not to do that. Do not do exercise. The macular is the portion of the retina that lets you see straight, right in the middle. So when you're looking straight, that's what is the signals from whatever object you're seeing is because of the macula. Then it projects back into the lens. So you're seeing because of this. This is the macular portion of the retina. So it's also a retinal problem, but a specific area. That is why this can be confusing. You see, it's a portion of the retina, but it can be confusing. It lets you see straight ahead. There's 2 parts. There's type 1 and there's type 2. Type 1 is, we call it dry macular degeneration, and the other one is wet. What is the difference? This dry one is the regular one. There's no vessel. There's no blood vessel going into the macular area. It's just that this is very thin. The word degeneration. You see, I told you scientists don't know how to describe things, so they use the same word to describe it. So macular as degenerated, something that is degenerating means it's getting smaller or it's losing its quality. So the macula is very thin. A wet form means there's the blood vessel has gone into the macula. So if this blood vessel has gone there and penetrated it and make and bleed basically into that segment. So this is blood vessel responsible for that. Macular degeneration, because this is not is ongoing problem. This is not acute. So not acute. So when you see a question, it said acute onset, you already eliminated macula. This is how you answer question. The key portion is not acute. So this is a gradual process. So this is going on for a long time. And what happened? You see where I told you pathophysiology play a major role when you study. We know the macula is make you see straight and see object straight, right in the middle. Therefore, if the macular area is degenerated or is affected, where I won't be able to see in the center, so you lose your central vision. Central vision is lost. It's the central vision, but it's a gradual loss of central vision. your peripheral vision, this is what they confuse you, is intact. Okay, peripheral vision intact. That's why you have to know. And they confuse you with glaucoma. Vision is lost, peripheral vision is intact. And what did they complain about? Well, they complain usually about blurred vision. Vision look really blurred. So it look a little bit blurred and it can't see really well. And it look distorted image, or it look wavy. You know, those are the buzzwords. Usually distorted and wavy are better than blurred, because there's another thing too that causes blurred vision. So I'll focus on distorted, wavy vision right in the middle. So they can see the center, but they can see the side of it. Okay. What is the risk factor that causes this problem? What is the risk factor? So there's a couple of risk factors. As you can see, this is the gradual onset. So age, as you get older, if you have it in the family history, of course, blood pressure is always a problem. You know, the studies that shows that smoking is not good because it's one of them. And then one of these vitamins, if you lacking carotenoids, so that's why we eat vegetables, so that we can get carotenoids, which help you with vitamin A and help with your vision really well. So that one, carotenoids, is very easy to get it. I mean, so you got to get some vegetables in your system, fruits and vegetables for that. I don't know if they will ask you guys. I like vegetables, and so carotenoid is one of those vegetables, especially tangerine. I eat all the time. So tangerine, example of carotenoids. No, in case they give you in a SATA form, example is like and tangerines. Okay. Tomatoes are very, very good with carotenoids, and cantaloupe also very good, and papaya, okay, and pumpkin, okay. So Halloween, pumpkin is also very good. It helps with that, and of course, don't forget your carrots. So these are source of carotenoids. So these patients, but that doesn't play a major role. Mostly risk factor is like age, family history, smoking, hypertension. But if you don't eat these carotenoids, you may develop one of them. Treatment is not the best. There's surgery for that, but it's not the best. Okay, there's no good treatment. You can slow down the process, but there's no real treatment for macular degeneration. You know, they can slow it down for you as much as they can. But this is the key things I want you to pay attention to is the diagnosis, that they lose central vision, the peripheral vision is intact. So if you give them an object, they will see this side. Okay, they will see one side of an object. If they give you a picture, this is what they see. Okay. And this side, the middle, is black. This is what you have to start anticipating things. They will trick you, they will draw these things. You have no clue. It's just application. You just rewriting. I'm just turning this into an image. So they see the red side, the middle portion, they don't see. And so they won't be able to see right in the middle, they will see. So they probably will turn their head to read on the corner of their head, whatever you keep giving them. So that is macular degeneration. It's not acute, it's a gradual onset process. This one, everybody know about it. So it's also very interesting. There's no way cataract will be acute onset. So this is a gradual onset. This is ongoing problem. So you can eliminate answer choice that you said somebody come in with the acute onset of high pain, you know it cannot be cataract. If the answer there, you just take it out. So it's a gradual process. The lens become cloudy. And if you wear glasses, when your lens is cloudy and you can't see, it's the same thing. This one, the lens in your eyes is getting cloudy. So the same vision you see. Once again, signs and symptoms, very important. There is no pain. I forget to mention macular degeneration, no pain at all. So this is painless and it's gradual onset. So you already eliminated retinal detachment if this is the problem. They will have double vision because something that is blurred, you see double vision, right? Their visual acuity, how sharp they can see, will decrease. So, which you can see when your lens is also cloudy, you can see anything. Another clue, if they give you a patient, is frequent change in prescription. They are 20/20 vision. They always, all the time, they have new prescription. Yeah, frequent change in eye prescription in terms of their Snell test or 20/20 vision. Yeah, you're talking about something. You have to tell you that something is wrong. Something, the lens is not working properly. It's not acute onset, but slowly every 6 months, their vision either get worse or a little bit, and that's what is telling you something is wrong. Okay, they usually worse at night, so these people don't like driving. They don't like driving at night at all because of the light. The light, they see so many flashes, and then they hate it. It's not like they're seeing flashes, true flashes, but it's reflecting in their eye, and then they don't like it. So this is what you see in cataract patients. So this one, they surgery for them to do surgery. Usually it's outpatient surgery under local anesthesia. The pre-op, the nurse, you should help dilate their eyes. So you give them medication that will dilate their eyes. They will need antibiotic and steroids. These are medication you give them. You dilate their eyes, Madratics in the eye to dilate it, and they will need somebody to take them home, antibiotic and a steroid. After surgery, you already know what to expect. So this is the thing about test-taking strategy. Whether it's macular degeneration, whether it's retina, whether it's cataract, whatever it is, if you operate in the eyes, you have to prevent intraocular pressure. It's the same thing. I don't have to repeat them, but it's the same thing. You want to prevent increase in pressure after the surgery. The treatment is the same. It never changes. So post-op management, the nurse, is prevent increase in intraocular pressure. That's all. You already know them. Sneezing, they don't bend. You keep their head straight. You don't turn them. You don't stimulate them too much. Head of the bed 30 to 40 degrees. All those things, you protect the eye. You put a patch on it. No pressure on the eyes. It's the same thing. It never changed. So don't separate them. It's what is a priority. This is not itchy and mild pain. So watch the question. They have surgery, all right. All they have is what? Pain and itchy is an expected finding. Don't do anything. I forget to say, like, they cannot exercise. I think I said it already. No exercise for 2 weeks, okay, after eye surgery, because in order to prevent intraocular pressure, okay. Photophobia, okay, after this, every time you have surgery to your eyes and you have sensitivity to light, that is normal. So that's also normal. So photophobia is not an emergency. It doesn't need a priority. It's normal with that. So that is cataract. The same thing, same management, the same precaution. But your key is this: to make that diagnosis painless, double vision, gradual loss of the lens. So glaucoma is interesting one. Okay, it's very important. There's two types. There's one, there's a, sometimes in the test, you see there's different fancy name. Don't worry about it. I usually call one close or open. I don't know, or you can put the acute. Yeah, so I think it's best. So one as acute at the end. Whenever you see the acute one, okay, if you see the acute one over there, then that is talking about closed. It's closed angle. So closed angle glaucoma. If you don't see acute over there, it's open. It's open angle glaucoma. So why is one cut closed and other one is open? It's because of the, I don't need to draw, but I'll draw it. The lens in the open, there's obstruction of flow of the fluid in the eyes. So the fluid is obstructed. So when the fluid is obstructed, it builds up. When it builds up in the eye, what it leads to, even though it's closed, what it leads to, there's too much pressure in the eye. So what happens is it dilates. So there's dilation of the eyes basically, and an increase in intraocular pressure. So that's the difference. This one is also is very slow onset. Even though they put an open, they are all the same. This one, that is what confuses people. Acute closed angle, and this is open angle glaucoma. It's the same process. This just happened all of a sudden, acute one. Second one, open angle, is the same thing. There's obstructing to the flow, but this one is gradual problem. Gradual flow loss, flow of blockage of the flow of the fluid, and so that become very important in terms of how they present. So this is an acute problem where acute onset then or sudden. And it's an acute problem. Every acute problem always painful. That's how you can, any problem that is acute onset has to give you pain. Your body has not have time to adjust. Okay, it has not have time to adjust anything at all. So there's acute onset of flow of the fluid in your eyes, such that the pressure is too much in the eyes, the eyes can contain it. So you have like rapid loss of vision. Basically, you're losing your vision just rapidly. And they have very severe pain. Pain is so severe inside the eyes or around the eyes. And then because of the pain is so bad, they may have nausea or vomit. So this is for the next gen. Then all these symptoms, you have to add it to it. Understand why they're doing that. And so it has to make sense to select those answers in case you see that. Of course, when you have severe pain, eye pain, they may have blurred vision. But that's not this is not the main point. The main point is acute onset, sudden, painful problem with a rapid loss of vision because your body has not had time to adjust to that. Okay. This one, open angle glaucoma, is different. Okay. The body have enough time, but there is also intraocular pressure is high. All of them, both of them, intraocular pressure is high, but it's a slow, gradual process. Gradual process. It's not acute onset right away. Slow, gradual process. Okay. And this is where you see the true meaning of glaucoma. This is why I hate when you write acute closed angle. It confuses residents, nurses, or students. It confuses them. And so sometimes they just put glaucoma. I prefer they just put glaucoma. Open angle glaucoma, which is like a slow, gradual loss of vision, you will see the true effect of glaucoma. And what is that? This one, you lose your peripheral vision. you're losing your peripheral vision, right? Unlike macular degeneration, what you're losing your central vision. Now, if I'm losing the peripheral vision, I will be looking straight, which is called tunnel vision. This is my pathophysiology. That's why I want you guys to, when you study, you got to know the disease process. So this is what we have. You have somebody like that. And so the vision is divided. We divide it in three. This is the center, and this is the peripheral. These people, they're going to lose their peripheral vision. So the peripheral vision is gone. It's gone like that. Or we just put black there. It's black. This is black. He doesn't see anything here. He doesn't see anything here. So when he has to see something, the only thing you will see is when the thing is looking straight. So they call them tunnel vision. So this is glaucoma. This is what happened to glaucoma shape. So when you give you an image like that, this is how you can answer it. Macular degeneration, well, the macula is right in the middle here. So they lose the central vision, but their peripheral vision is fine. So they see on the side. So this is a macular degeneration. It's different from glaucoma. On acute closed angle glaucoma, you don't see this. This is that basically everything is gone. You're losing all of this because it's acute onset. Your body have not had time to adjust, so it's affecting everything. The only time they will ask you which one, the answer choice will be glaucoma. If they don't put it, they will put open angle glaucoma. So they will lose their what do they call it? The tunnel vision, and it's not painful once again because it's not acute onset, so no pain, painless. It's not painful at all, and their central vision is intact. So central vision is intact instead of loss of the peripheral vision. They may see halos around the vision. They will see some glaring. And usually this can be bilateral or unilateral. And that makes sense. This is a gradual process. So something is affecting it, something systematically. There's too much pressure in the eye. So it's affecting both optic nerve at the back. Okay, affecting both optic nerve. So they may lose both eyes, left and right. In acute angle glaucoma, is usually one side. Something happened to one of your eyes and you lose it. In open angle, you can have both one side or two sides. So just pay attention to the difference between them. And you can see that we have an emergent problem and a gradual problem. So this one, treatment, what do you think? Emergency surgery. If you don't do that, patient lose their head. So this is a patient you have to see. This is one of the B-sharp patient. So angle glaucoma and the retinal detachment is eye pain that need to be seen right away. If you don't do that, they lose their eyes. So that is not something you have to sit on it. So this treatment, emergency surgery. This one is what ophthalmology is all about, glaucoma, and that is where we do pharmacology treatment for this. So let me clean this. So I'm talking about this is where most of your pharmacology is based on in terms of the question they ask you, because this one, initially you can do some prevention before you attempt to do surgery on them. So the treatment, number one treatment is mostly intervention, is to prevent the pressure. You want to decrease the pressure in the eyes as soon as possible. Okay, so you want to prevent the pressure. So what do? First of all, once again, there's obstructing to the flow, okay, such that there's too much pressure in the eyes. And so the eyes is really, really what? Basically there's too much pressure, so it dilates. The eyes is dilated. That's another one. Pressure slash dilation. So to treat them, you want to constrict. Okay, you want to constrict the eyes to decrease the too much pressure. And this is what you're going to use to find any pharmacology that will do that. That is all what it's about. The pharmacology is based on this treatment. There's too much pressure, which we can decrease the flow of the fluid, and the eyes is too dilated, so we can constrict it. So we will have to look for medication that will do that. Okay, medication that will decrease the flow or decrease the secretion, and then will prevent dilation. It will cause this constriction. So this is the pharmacology. So this is the pharmacology aspect of it. Okay. So there's a bunch of medications that can do that. So what medication causes constriction of your eyes? So it's cholinergic medication. So anything that you know that is cholinergic can do that. Of course, there's specific cholinergic medication that is known for ophthalmology. Okay, so one of them is Pilocarpine. There's only like 4 or 5 medications for your eyes. So when you see them in the pharmacology question, it's just a free answer choice. So cholinergic or carbachol. Whenever you see this word carbachol, even if it's in bladder medication or anything like that, call are always anticholinergic calls. So COL. When you see them, no, they are cholinergic. Sorry, I misspoke. Calls are cholinergic. So carbachol and pilocarpine. These are 2 specific ophthalmologic medications that are cholinergic, that will cause constriction, that will prevent progression of the glaucoma. The other medication is it's a beta blocker. So beta blockers can be used for this also. They can cause constriction of the eye, the pupil, and that will prevent the decrease the pressure in the eyes. And one of them, so a beta blocker, the specific one. So this one is timolol, and you see it all the time. If you go to the pharmacy, you see them, they give it to people all the time. Yeah, it's a beta blocker, and that will decrease help decrease intraocular pressure, and help with that. That's one. And there's another one, Lavo B. No, I think it's B, like bimatoprost. He has a last name, levobunolol. That's his last name. And they all have law as a beta blocker, basically, beta agonist, beta receptor blockers. And so they're going to cause constriction, and then that will help decrease it. So we're just using the pharmacology. So, like I said, we're using pharmacology. The pharmacology, when you memorize it, you forget it. You find what is the problem and what kind of class of medication you can use to answer it. They will give you multiple choice, and you just have to put them in the class. We know this is a beta blocker, and the beta blocker causes constriction of the eyes, well, of the pupil. Therefore, that's the idea we want. We want something like that. The other one is, I told you, we want to decrease flow. Okay, we want to decrease flow. Too much pressure is due to the fluid, which is blocked. So for the flow of fluid, then we can use this acetazolamide. This is what we call diamonds. I don't think they will use that name. They probably will use this acetazolamide. It's a carbon. You can use it in the renal disease too. Carbonic anhydrase inhibitor. Yeah, so this medication is also very important. Acetazolamide is another that will help with the flow. It decreases the blood flow and the fluid and secretion. That will decrease the pressure in the eyes. There's few medications that doesn't follow pattern, but they do the same thing. Like I said, they do other different thing. Like this, they are prostaglandins. So these are prostaglandins. They specifically is they have names that we've seen it before. I think Prost or something. Yeah, latanoprost. Okay, his other friend is bimatoprost. They are the prost. I remember they are the prost. Yeah, the prost. So if you've done some questions before, you see this on the eye. You see them. I call them the prost. You just pay attention to the last name when you see them. Prost. They are prostaglandins analog, and that also can use to cause constriction of the pupil. The problem with them is they causes your iris. So if you give it to them, you got to tell the patient the iris, brown iris. The iris will look brown. So they shouldn't worry about it. That is the symptoms, especially latanoprost. That's what causes. They will make latanoprost will make your iris brown. Okay. And then, like I said, there's other medications you can use, but these are the common ones that sometimes they ask you to identify them. One key thing about I don't see here is pilocarpine. Okay, this pilocarpine here, it can cause retinal detachment. So you got to be careful. Too much constriction, chlorine. So pilocarpine side effect is retinal detachment. And this is all the pharmacology you need to know. And as you can see, the one medication you should avoid in these people is anticholinergic, because anticholinergic will dilate your pupil, okay? And that can increase your intraocular pressure. This is something you shouldn't forget. It's part of the anticholinergic symptoms. They can pee, okay? They can, they have constipation, they can salivate, and they have vision problem. The vision problem is this, glaucoma. It worsens patient glaucoma. So anybody who has glaucoma and you're giving them anticholinergic, you got to be careful. It's going to worsen their glaucoma. They're going to have problem. So you should avoid that. The other one is avoid antihistamine. The same thing. They have some anticholinergic effect. Antihistamines and or you don't call them anti-decongestant. These three things you should avoid in patients who have glaucoma: antihistamine, decongestant, and anticholinergic. They will worsen their problem. In the question, when they ask you about a patient who has glaucoma, the number one thing you should tell them is continue taking your med and never stop doing that. You have to teach them how to use those medications. Otherwise, they will infect their eyes. They have to use it for a long time. So you got to do the teaching of how you apply drops to the eyes. They put you have to describe it. I mean, so that they know how to do it. They have to practice. You got to teach them how to use application of that. And it's very important. And you tell them, well, this is for life. Eye drops for life. Glaucoma, eye drops for life. That's the slogan. Eye drops for life. If you have glaucoma, eye drops for life. If you want to lose your vision, then eye drops for life. That's, you want them. They should not stop taking it, even though they're feeling good. So this is everything about these 4 diagnoses: glaucoma, loss of your peripheral vision. It can be acute onset versus gradual onset. They need eye drops, and that is where the bulk of pharmacology of your eyes is based on. You should avoid anticholinergic. The idea of the increase in intraocular pressure is because of too much dilation or too much fluid. We want to constrict. So we give them medication that will constrict. We give them cholinergic. We give them a beta blocker. We give them prostaglandin. And then we give them acetazolamide, which is a diamage to decrease fluid secretion. They will need eye drops the rest of their life. You have to teach them how to take care of it. The retinal detachment is an acute onset. They need emergency. They have to go to the emergency room. Post-surgery, intraocular pressure management. And then the rest, macular degeneration, which is a mostly central vision loss with intact peripheral, and cataract, which is cloudiness of the lens and blur and glaring. They are non-acute, they are gradual, they are less painful, they are not painful, they may have this and they may not show symptoms. All of them is very important, and you should be able to distinguish between them. Thank you for listening, and take care of yourself. Keep charging, and visit my YouTube channel and subscribe and get more content so that you can have a pop-up of those content whenever I put new content. Have a good day and best of luck in your exams.